So let's begin. And my topic today is mechanical power. I'll just share my slides. When this topic was given to me, honestly, it's a little confusing topic, and I did do a lot of research, cleared my own concepts, so that I could do a little justice to how I explain it. So as we go ahead, I will first speak about a few basic concepts that we need to know about mechanical ventilation, because without these clarity of the concepts, probably understanding mechanical power will not be easy. Mechanical power can be understood just as the sake for it, that it is these components and this is how it is calculated. And with artificial intelligence coming up, probably the new ventilators probably will give us a value of mechanical power, like how we get values of compliance and resistance now on most of the ventilators. So it's not about that. It is about understanding what it means and understanding how we need to use it on our daily life to protect our ventilators. And once we understand the concept of it, we need to know what do we really need it and how can we uh, change this mechanical power for the benefit of our patients. So when we are ventilating our patients, or when we put our patients on ventilator, whether it is ARDS ventilations, a COPD patient, or a non-ARDS regular patient, a post-op patient, our target when we ventilate our patient is to optimize ventilator settings. Now, when I say optimize ventilator settings, is to deliver the required amount of minute ventilation with a good amount of synchrony and to avoid any harms that are related to the ventilator. So most of the studies that have been because of the mechanical on mechanical power, the terminology came in 2016 by Gattinoni, who has been doing a lot of work on ARDS, and most of the studies are about ARDS. And I just found one article which speaks about non-ARDS related mechanical power. Uh, uh, so, so when we, as I said, when we deliver ventilation to any of our patients, we want to optimize the settings to the benefit and avoid harm. So when we started ventilating these ARDS patients way back in 1960s, when the term was described and when the first studies came in, the first thing that we talked of was low tidal volume. That high tidal volume was harming our patients. We needed to limit the tidal volume, and that is what we called as the lung protective ventilation, so that we can avoid ventilator-induced lung injury. So when we were avoiding going ahead with this, it was about the lung protective ventilation, as I said. Okay. The lung protective ventilation. Sorry. Okay. So we were talking about the lung protective ventilation. And when this lung protective ventilation started, it was about giving the least amount of tidal volume. And then as the studies more and more progressed, the next terminology that we came to know was the plateau pressure. And this plateau pressure, then the new term came that we have to limit this plateau pressure to about 30. And then the new number came to 28. And then we came to a new terminology, which is a driving pressure. And driving pressure is the difference between a plateau pressure and the peak. So these are the things that we were asked to limit. And while we were limiting all this, we were told that we can avoid, we can allow a little amount of carbon dioxide to rise, which was called as the permissive hypercarbia. And with all this, the attempt was to control the ventilator-induced lung injury so that the ARDS does not progress, and we allow the baby lung of ARDS to improve or to recover from the insult that has happened. So when the ventilator-induced lung injury was defined, again, it was defined first as volume trauma, and it was said that it is volume, which is causing the harm to the patient. So that is why it came to limiting tidal volume to 6 ml per kg. Then it came to barotrauma. Know that, we need to limit the pressures as well. We need to keep the plateau pressure of 30. And then it came like, no. Even if we limit the pressures, there is something called as atelectotrauma, which happens because we are inflating and deflating the lungs. And this atelectotrauma can be avoided by keeping the lungs open. And so you go ahead and give a very good PEEP. And then because of all these things that you're doing, there is a lot of cytokines which are released. And then there is a good amount of biotrauma which is happening. And now, after 2016, all this is clubbed up to one single term, which is called as ergotrauma. That is the harm that is happening because of the ventilator due to the energy that the ventilator is delivering to the patient's lungs or the mechanical power of the ventilator. Okay. So understanding these traumas, we need to understand again two more terminologies, that is stress and strain. What really is stress and strain? These come from the physics or the mechanical energy biophysics that was there. So let us see what this physics is about. Okay, just a second. Let me remove that annotations. Okay. So before we go ahead, there's another thing that we all need to know is the equation of motion. Okay. Equation of motion very well explained in chat by Chatburn. And it says that any amount of work, the work of breathing that is done by the ventilator or the work of breathing that is done to maintain the minute ventilation or the uh, requirements of the body are the work which is done by the ventilator as well as the work done by the patient himself. Now, let us consider that this P muscle is zero because I do not want to confuse it further and say that our ARDS patient is completely sedated and paralyzed. So, we say that the work done by the ventilator is basically divided into three components. The work to keep the lungs open or to overcome the atelectasis or to overcome the static low compliance or to open up the lungs, that is the work done by P. Then the work done to allow the airflow or the gas to flow through the airways, which is a product of the resistance which is provided by these airways and the flow that you set by the ventilator on the ventilator, or the flow and the flow with which the gas flows in, and the work which is done to overcome the elastance of the lungs or the poor compliance. Elastance and compliance are opposite terms, and which depends upon the tidal volume you deliver divided by what is the compliance of the lungs. So there are three works that a ventilator does. Okay. So there is a static elastance work, which is done by the PEEP. Then there is a dynamic elastance work, which is done by the tidal, which is defined by the tidal volume divided by the compliance. And there is a resistive work, which is mainly the resistance provided by the airways multiplied by the airflow. So as I said, let us see what is stress and strain. The stress is what we give. That is the pressures we give to the lung so that we can deliver the amount of volume that we want to deliver. Okay. So if I say that the baby lung is small, as we can see in the first figure here, that the baby lung is very small, and this baby lung, just a second. So this baby lung is very minimal, almost as the size of a walnut. Now, if I'm giving certain amount of pressure to this baby lung, okay, this is going to damage. Then there is another baby lung, which is the size of a coconut, a small coconut. And there's a baby lung, which is the size of a big coconut. Now, when I'm delivering the same amount of pressure to these three types of baby lungs, obviously, the harm that will be there in the walnut will be more than what is there in the bigger green coconut, because there are more FRC or more alveoli which are open in this lung, and this allows uh, uh, more pressure to be taken up by the lungs. So when I say that I have to keep a driving pressure limited, am I being unfair? Yes, I am. So we cannot really go by pure pressure alone. There are various components that we need to see, that how big is the baby lung or how small is the baby lung that whom we are treating. So this is the stress which we provide to the lung by giving the pressure. So this is what is stress. Stress is what you deliver. A stress is kind of the barotrauma that you are delivering to the patient, to the lungs, so that the lungs inflate in the amount of volume that you want to give him to maintain the minute ventilation in the lungs. And then what is strain? So when we deliver this pressure or this volume into these lungs, if I have two tires, a tire which is a cycle tire, it is going to deform much more for the same volume as compared to the tire when I inflate air into this tire of this MRF big truck tire, it is going to deform less. So the volume trauma that is going to happen in this bigger tire is going to be much lesser as compared to the same volume when I deliver to this tire, right? So this is a strain. So the change of shape that happens when I deliver the stress to the lungs is what is called as the strain. So the strain is actually what is the FRC. So the FRC of this truck tire, MRF tire is much more as compared to the smaller tire. So the volume that I deliver and which causes the change in the shape is called as the strain. So this is the difference between the stress and the strain. So by giving the stress, in a way, I'm giving a barotrauma. And when I'm making a change in the volume or change in the shape of the lungs to deliver that, when I deliver that pressure and the flow that happens, I am actually delivering a volume trauma. Okay, so this is the difference between the stress and the strain. So as I said, again, now to limit all the stress, all the strain that we are doing, what we need to prevent or what we are trying to find out by this mechanical power, the timeline that happened was first a low tidal volume, then a low peep plat, then we decided to optimize the peep, and still we are confused what is the optimum peep for a patient. There are various studies which are coming up, and it's a topic of its own, how to get the optimum peep. Then a driving pressure, and finally we are to this terminology of mechanical power to limit the ventilator-induced lung injury. So what exactly is mechanical power? The mechanical power is the energy which is transferred from the ventilator to the respiratory system within a time frame. So there are two things. It is the energy which is going from the ventilator, or the power, the mechanical energy in the ventilator that is used to push the air into the respiratory system so that the respiratory system inflates, or there is some amount of strain which is happening in the respiratory system within a given time frame. That is called as the power. So it is expressed as joules per minute. It is within a time frame. Okay, just this is the basic definition that is there. I am not expecting you to understand anything by this definition. I will try to break down this definition into multiple components so that you understand what it is. So let us first again look into some physics. Okay. So in physics, while we were in our fourth standards, our fifth standards, the first law of thermodynamics that we learned is energy cannot be created or destroyed. So obviously, you have some energy that is there of the ventilator, which is being given to the lungs. So there is some energy which is delivered to the lungs. Okay. It was not created anywhere. It was not, the electrical energy was converted into a energy, and this energy finally, mechanical energy finally went into the lungs to inflate our lungs, and that is what is called as the mechanical power. Okay. Now, another thing that we learned at the same time, that energy is of two forms. It is a potential energy and there is a kinetic energy. Okay. The potential energy is the static energy or the stored energy, and the kinetic energy is the energy of the motion. Obviously, so that we already saw the equation of the motion. The potential energy is what the peep does. The peep energy of the peep is to overcome the static compliance or the collapse of the lungs, or static elastance of the lungs. So to keep those alveoli slightly open to improve the FRC. So that is the PEEP is the mean potential energy which is getting delivered inside the lungs. And the kinetic energy is to overcome the elastic forces as we deliver the tidal volume, and also to overcome the resistive forces of the airway, as we saw in the equation of motion 2 slides back. Okay. So mechanical energy is in joules. And when we put this as a time frame, because we are delivering a minute ventilation, we are not delivering a static or a one-time ventilation. It is happening multiple times during a minute. And that is why we have to take it per minute. And that becomes the mechanical power, that is joules per minute. So how do you calculate this mechanical power? There are various formulas. Since in 2016, Gattinoni described this terminology, there are various studies, various powers that happened, and Gattinoni gave a very complicated formula, and there were more and more people who came up with more and more formulas, and the simpler formula that we can reach or use is the one which is given in 2019 by Giosa et al. And it is one of the simplest equation. Okay. And then there is mechanical power, which is also defined as per the mode of the ventilation. So there's a different mechanical power calculation in the mode of ventilation of volume control, and there's a different mechanical power calculation which happens in a pressure control mode. And to complicate matters further and further, and to confuse you all a little more further. However, there is a very thin line between confusion and clarity, and I will come down and break down these components to give you a simple formula which was described by Giosa et al. And which you can use at the bedside and understand at the bedside, even if you don't remember the formula, understand at the bedside what you need to do so that to reduce the ventilator-induced lung injury. So coming back to our equation of motion, it is one of the best things that has been described. And if you want to understand mechanical ventilation based on equation of motion, there's a fantastic book by Chad Byrne, and it just changes your understanding of mechanical ventilation. And believe me, you can use any ventilator once you read that book. So coming back to what I said was equation of motion. So there is this, if you can see here, the yellow part, the B part is the one which is the work which is done by the PEEP. Now this PEEP, when I deliver a PEEP constantly, there is some amount of volume change which is happening because the PEEP has recruited some lung or alveolar components, right? So there is some volume which has increased, or the static compliance of the lung has improved a bit by delivering this PEEP. So this is the static work which was done. So the PEEP will play some amount of role in this mechanical power. Then when this air is delivered, the pressures rise further to the peak pressure. So this point is the peak pressure. This is a volume control mode. And then this is the resistive work, which is the green component. And then there is this elastic work, the dynamic elastic work, which is the C orange component. And this point is the plateau pressure. This point is the peak pressure. Okay. So the work which is done, or the power that is used by the PEEP, can be defined as PEEP into tidal volume. The work which is done to overcome the elastic dynamic elastic component will be the P plat minus the PEEP multiplied by the tidal volume. Okay, because the tidal volume will be get delivered, only then will this change, which will, the role played is half, so it is multiplied by 0.5. And then there is a resistive component, and the resistive component, when the air is flowing, the pressure that we take is the P peak. So it is P peak minus the P plat, only this green part multiplied by the tidal volume. So the work or the power that is used, energy that is used to overcome this component is the P peak minus plat into the tidal volume. The same thing or the same rules apply here in pressure control ventilation. However, we need to remember that the pressures become limited, or the P peak becomes limited in case of the pressure control ventilation, and the P peak and P plat are actually at the same level or the same value as the in a pressure control ventilation, because what we are limiting is the pressure in a pressure control. So to simplify it, all you need to remember is the static compliance work is done by the PEEP, and this energy will be defined as PEEP multiplied by the tidal volume. The dynamic compliance overcome the dynamic compliance or the dynamic elastance to work, the work that will be done will be the P plat minus the P multiplied by the tidal volume. And the resistive component will be the P peak multiplied minus the P plat, not the P. Okay. It is just the difference between these 2 points, that is the P peak and P plat multiplied by the tidal volume. Okay. So this is the pressures that you have to take for the resistive work. Okay. So this is one basic step that we remember, and we go ahead. So as I said, a complicated formula was given by Gattinoni when he may define the terminology. But to make it simpler, the power was defined as tidal volume, which was a part of every equation that we saw in the previous slide, multiplied by the respiratory rate, because we are saying this is a component of the minute or the time. The mechanical power can be defined only per unit time. So we have to take the respiratory rate into consideration, which is multiplied by PEEP, which is to overcome the static elastance of the lungs. Then the dynamic elastance overcoming is by the half of the P plat minus the PEEP, which is the driving pressure, and and the subtraction of P plat by P peak, which is the resistive component, right? So again, I have divided it. It is this 0.098 is the constant, okay, which arised after the equation or after the research which Gattinoni did, okay? So a constant multiplied by the tidal volume that you delivered, multiplying by for the unit of time, we are taking the respiratory rate into consideration. The PEEP we are taking to overcome the static elastance work. The dynamic elastance work, we are taking the driving pressure, half of it. And to overcome the resistive work, we are taking P peak minus the P plat. Okay. Adding all these together, so this becomes our simple equation of mechanical power. Okay. So the power is used, or the energy is used to overcome the static elastance, the dynamic elastance, and the resistance of the lungs. As simple, and this you have to multiply by the minute ventilation, because what we are talking of is per unit time. The minute ventilation is tidal volume into respiratory. Still confusing? Still, it is a little difficult because every time I have to calculate the mechanical power, I have to go and find out what is the P flat of the patient. Every time I have to give him an inspiratory hold to assess what the mechanical power will be. So let us make it more simpler. Now, this is a surrogate of the mechanical power. It exactly isn't the mechanical power, and multiple equations and multiple calculations, multiple studies was done in rats by Giosa et al. In 2019 to give a more simpler equation. So this is the same equation which I took from the previous slide. Okay. I have made the driving pressure P flat minus the P. So it is again the same. And this is the minute ventilation, which I have written as VE. Okay. So the P into 0.5 into the driving pressure plus the resistive work. Now to simplify it further, 0.08, he made it into 0.1. Okay. Why to complicate it further? He just cancelled out this P flat because he felt anyways it's a minus. Why should I bother it much? Fine. Just cancel it out. Okay. But he retained the PEEP half. Okay. He made it as PEEP because it is PEEP minus 0.5 of the PEEP. So it is PEEP divided by 2, right? Plus the P peak divided by 2. But when we are removing the P flat, we are removing a huge component. So what he added was the flow divided by the 6. Okay. The air flow divided by 6. And this again came by a lot of experiments. This number 6 came by a lot of experiments. And since there was 0.1, which was 1 by 10, he just made it 1 by 10 into 2, that is 20. So it is minute ventilation into P peak plus P plus the flow divided by 6 divided by 20. So this is the simplest formula that you can use at the bedside to understand what is or to calculate your mechanical power. So what are the limits that you need to know for mechanical power? We gave you the limits for the tidal volume, 6 mLs per kg. And we gave you a limit for driving pressure. We gave you a limit for P plateau. We gave you a limit for respiratory rate to allow permissive hypercapnia. So a lot of initial studies went into finding out what is this number which we need to tell you that, you cannot cross beyond this number. You cannot cross mechanical power beyond this number. So the number which came in ARDS lungs was 17. Studies showed that more than 17. In pigs, actually, the initial number that came was 12. But when human studies were done, the number that it came in for a ARDS lung, that you try to keep your mechanical power less than 17 joules per minute, because if you cross this number, it increases mortality. Okay. So in 2016, Gurin did another study similar time, and he found that yes, mechanical power does correlate with survival. And every time you increase the mechanical power by 1 unit, that is 1 joule per minute, you are increasing the hazard ratio by 1.01. You are increasing the mortality proportionately beyond the number of 17. So we have to limit our mechanical power to this number, 17 joules per minute. Another study in 2018 said that even if you are giving a low tidal volume, that is less than 6 mils per kg, you are giving a low driving pressure, less than 28 centimeters of water, and if your mechanical power is higher, that is above the 17, okay, your mortality does increase. Okay, so a single factor of volume and pressure does not matter. It is a component or a combination of all these factors that even if you limit your volume, so mechanical power is very important, and we need to put it in our practice to understand where we are leading or why our patients are not doing well. And then, since we talk a lot about everything per weight, Zhang et al. Decided that I would probably look at mechanical power per predicted body weight. We can't look at an absolute number of mechanical power. We need to divide it by the predicted body weight. And he called this as normalized mechanical power. Okay. So when he said, when we are looking at predicted body weight based mechanical power, it is superior to the absolute value of mechanical power. And it showed that in moderate to severe ARDS, when this normalized mechanical power was found to have a linear correlation with mortality. But in mild ARDS, this was not seen. So this was seen mainly in moderate and in severe ARDS, but not in mild ARDS. And this is a fantastic study which was done in 2021. And this time they studied a lot of components together. All the components which define mechanical power. The components which define mechanical power are respiratory rate, tidal volume, driving pressure, PEEP, plateau pressure, and all these components to put together as a mechanical power. So when they looked at which components of these really do matter, okay, do they individually matter? Or so this was a retrospective analysis. This was not a study which is done currently. They analyzed all the ARD studies which occurred in the past, and they calculated the mechanical power, putting those components together. And when they put these 8 studies together, and there were a huge number of patients, 8,000 plus patients which were there, and they put all of these together, they found that mechanical power does correlate to mortality. And the second thing which correlates well with the mortality, all of these components do correlate, but one which correlates more to mortality is the driving pressure. The respiratory rate, in fact, was found to correlate more than the tidal volume. But we have always given importance to tidal volume and not to the respiratory rate. PEEP correlates, the plateau pressures correlate. However, the one which most likely correlated was the driving pressure. Then he also found another component, because he found that yes, driving pressure does make a difference and respiratory rate does make a difference. So he made another formula where he multiplied 4 times of driving pressure plus respiratory rate. And when he combined the driving pressure and respiratory rate together, it found out that they found out that this correlated more with mortality than with mechanical power alone. Okay, so you never know, you may have a newer component or newer definition coming up soon, which will define ventilator-induced lung injury in a more complicated or maybe a more simpler manner, because it's easier for me to have the driving pressure and the respiratory rate, right? So, yes, now I have understood that I have to keep my mechanical power low. Multiple studies, multiple slides told you that. Fine, I understood what it is. I know it has to be kept low. I know how to calculate it. But how am I going to put this in practice? What am I supposed to do so that I can keep this mechanical power low? Okay, let's see. So we have to optimize all of these mechanical power components. That is, we have to optimize our tidal volume. We have always been doing that. We have to optimize our driving pressure. We have always been doing that. We also have to optimize our respiratory rate. We cannot ignore it completely. Okay, and we also have to optimize our flow, our peak flow that we deliver. Okay, and that is the reason why the pressure control ventilation is always found to be superior to volume control ventilation, because there's a flow limitation in this pressure control ventilation. The flows do not go very high, right? It is a decelerating flow patterns, and that is how this explains. We have always seen, there have been studies which shows that yeah, pressure control ventilation is better than volume control ventilation in ARDS. Okay, so yes, we have to limit our flow, and probably choosing a pressure control or a PRVC mode will be much better. Okay. So now let's break down further. Now there were studies which we saw the previous study also, and where it says that the studies which showed that when we increase the tidal volume by 20%, the mechanical power increases by 37%, which is huge. Okay. So even at low mechanical power, a higher tidal volume was associated with ventilator-induced lung injury. So we cannot say that I'm going to keep the mechanical power less than 17, but I'm going to deliver a tidal volume of 9 mils per kg. Because I've limited the respiratory rate, I've limited the driving pressure or whatnot. So we cannot take that as a surrogate, that only mechanical power is sufficient. So even when you keep a lower mechanical power, a high tidal volume is not allowed. We have to limit our tidal volume. Okay, and we also have to limit our mechanical power. However, when both these factors were looked together, that is the tidal volume and the respiratory rate, the tidal volume was found to be more important or more important than the respiratory rate. The tidal volume, when in the minute ventilation, the tidal volume was found to be more important than the respiratory rate. So then the study came up, and they decided to reduce the tidal volume and to lower the mechanical power in all of these conditions. Okay, so then these are these lungs with a compliance of 40, and this lung with a compliance of 20, a bad lung, a moderate to severe lung. Okay, and they limited the tidal volume. They limited their plateau pressures. They limited, I think I have just put this figure twice. I'm so sorry about it. because I don't know why I've just taken this figure twice. This is a replica of this, but there's another lung with a compliance of 60. Okay, I'm so sorry about this. I've just put the same figure twice. Sorry. Okay, so just let's ignore that. So this study, which is published again in 2021, it showed that reduction in tidal volume was associated with a lower mechanical power in all lung compliances. That is in mild ARDS to moderate to severe ARDS. A reduction in tidal volume led to a reduction in the mechanical power. However, it was seen that when you decrease the tidal volume from 10 mL to 6 mL per kg in a mild lung, the mechanical power reduces only by 9%. Okay. I do not have that 9% size in the mild lung, which is only by 9%. Whereas if you do this in a moderate ARDS, then the mechanical power reduces by 11%. However, when you reduce this at a very low compliance lung, then when you reduce the tidal volume, the mechanical power drops by 19%. So from mild to moderate to severe ARDS, the decrease in tidal volume is very significant. Okay, reducing tidal volume is very important to keep a low tidal volume ventilation in our ARDS patients. The next component that we need to look at is the flow. Flow was equally important. So when the flow was increased by 20%, again the mechanical power increased by 37%. And this is not a mistake. It is the same number which is given for flow as well as the tidal volume, the previous slide I just said. The mechanical power was shown to increase exponentially when both the flow and the respiratory rate increased. So if you increase the respiratory rate, the flow will proportionately increase. Okay. So when you increase both of them, the mechanical power just jumped up. A sudden deflation also had a higher potential for lung deflation, lung damage. So we cannot have a sudden deflation as well. And that is the reason why low tidal volume is important. Okay. So, and the flow is what matters in the mode of ventilation which is seen. And that is the reason why the mechanical power was higher in the volume control mode as compared to a pressure control mode, which has a decelerating flow pattern or a flow limitation. Okay, so giving a higher respiratory rate is not an answer. Okay, next PEEP. The PEEP played the least amount of role in increasing the mechanical power. When the PEEP was increased by 20%, the mechanical power increased by 5.7%. It is more of a potential force that keeps the lungs open at one time, so probably it causes less harm. Also, PEEP increases the end expiratory lung volume. It modifies the lung surface area, which can take the stress that is given, okay, by the mechanical ventilator. And that is probably why the PEEP does not do harm. So giving the potential recruitability of the lungs, if we give an optimum PEEP, the PEEP does not worsen the mechanical power as much. So how do we optimize this now? So we have to optimize all the components that we saw. We will, first of all, we need to reduce the CO2 production so that we can reduce the flow, we can reduce the respiratory rate to maintain the CO2 levels and the pH levels. And we need to achieve this by giving them a good amount of sedation, we give them good analgesia. SOS, if required, we may add paralytics and to control the fever. So one important component that we have to reduce the flow and the respiratory rate, which are playing a very important role in the mechanical power equation. We have to enhance the ventilator efficiency. Why? How we can enhance this? By reducing our dead space, by giving a little end inspiratory pause so that the flow is a little lower, by recruiting more with prone ventilation and with optimizing our PEEPs. Do we have a role of newer modes? Yes, let's see which newer modes can help us optimize the mechanical power and when to use ECMO based on our mechanical power calculation. So the newer modes, the adaptive support ventilation by Hamilton, okay, there was a study which was published in 2021. However, it is a very small study of only 24 patients, a single center pilot study, which showed that as compared to conventional ventilation, okay, the mechanical power was lower when an adaptive support ventilation was used. So the average mechanical power is when a conventional ventilation was used for an ARDS patient was 22, whereas the average mechanical power was 15 when an adaptive support ventilation was used. And this was seen throughout all the timelines that was seen. All throughout the timelines, you can see that the mechanical power is lower with the adaptive support ventilation as compared to the conventional ventilation. Okay. So what is adaptive support ventilation? Adaptive support ventilation is a closed loop ventilation wherein you feed certain factors and there are certain returns that is there. Most of the calculation is done by the ventilator itself. This is a more of a artificial intelligence run ventilation where the role of the intensivist reduces. So when you give adaptive support ventilation, the data that you enter is the patient's body weight, the minute ventilation that you desire in this patient, minimum minute ventilation, the PEEP has to be entered by you and the trigger has to be entered by you. Based on these entries and based on the first breath that is there, the ventilator will measure the compliance of the lung and the resistance of the lung. And based on this calculation, it will, based on the algorithm which is fed in the ventilator, the patient will generate, the ventilator will generate its own point where it will decide what tidal volume and what respiratory rate has to be delivered with the optimum IE ratio so that there is no auto peep. And based on the resistance and compliance, it will decide to go up or down. An optimum minute ventilation that you have set will be delivered with the least amount of mechanical power. So this is one mode that can be thought of using if possible. Then it was decided, which we already found out that 17 was a number which was bad for mechanical power. But does it really help us take further decisions? Yes. So mechanical power tolerance was seen by Sarpa et al. And it saw the mechanical power in various patients, even in non-ARDS lungs. And it showed that in normal lungs, the mechanical power is approximately 12, less than 12. Okay. In non-ARDS ventilated lungs with some other diseases, 17 is okay. But as the ARDS worsened, the mechanical power was worser and worser, going from mild more than 17 to in mild to more than 22 in moderate to more than 24 in uh, uh, severe ARDS. And our threshold value that we need to have is less than 17. However, it also says that if your mechanical power is started to exceeding 27, it is the point where ECMO needs to be considered so that we can protect the lungs and not ventilate them. Maybe proning can be considered a little earlier than this, maybe at the level of value of 22 itself, which may further studies may define it. It is very early to comment, but based on this study. So based on this, I would conclude that the degree of damage that happens to the lungs is based on what is the energy which is transferred from the mechanical ventilator to the respiratory system within a given time frame. And this is what is the mechanical power. There are various formulas from simple to complex, and you may depend on which one do you want to use. The focus is to normalize it, to limit it preferably to less than 17. In all the components that are there, the kinetic components hold more importance than the static components. That is the flow, the tidal volume, the respiratory rate. They hold more importance. The PEEP plateau holds more importance than the PEEP, which is a static component. And thank you so much for this opportunity.